Regarding the treatment of premenopausal women with ER-positive, HER2-negative early breast cancer, there are a few messages that are important, namely, starting with the fact that there is usually a worse prognosis. We don't totally know the reasons, but there are a couple of reasons why this happens. One of them, or probably the one that seems the most important, is a different distribution of the subtypes within the overall breast cancer population. And we know that there are more triple negatives, more HER2 positives, and there are more luminal Bs than luminal As in a young woman than, for example, in a postmenopausal woman. So if there are more luminal Bs than luminal As, relatively, the prognosis may be worse. We also know that young women tend to have higher risk characteristics in terms of clinical pathological characteristics. For example, more grade 3, more node positive, and larger tumors. The other reason why the prognosis is worse has to do with compliance. So compliance with oral treatments is always a problem in cancer, particularly in the curative setting, where the patient feels well, there is no visible disease, and therefore the balance between the potential efficacy and the side effects is one that usually patients are not willing to tolerate a high level of side effects. So, and this is an important point to take into consideration for the available options that we are going to discuss. So in terms of endocrine therapy agents, the mainstay of the treatment is tamoxifen. So this is a treatment that has proven efficacy and has changed the lives of early breast cancer patients of all the ages and all the menopausal status. The questions for premenopausal women is when to use tamoxifen alone or when to add ovarian function suppression or ablation. The indications of ovarian function suppression have been better defined in these last few years with the SOFT trial. So in this trial, we have looked into the comparison of tamoxifen alone, tamoxifen plus ovarian suppression or ablation, and aromatase inhibitor plus ovarian suppression or ablation. And what we have seen with this trial that now has about 9 years follow-up is that we see that for high-risk patients, and I'll come back on how to characterize the high-risk patients. For high-risk patients, ovarian function suppression adds in terms of disease-free survival and also in terms of overall survival. Small benefit still, but it is there for the addition of ovarian function suppression or ablation. How do we characterize this high risk? In SOFT, there was no randomization for chemotherapy, but there was an allocation based on physician decision. And what were the factors that physicians took? So size of the tumor, nodal status, grade, and even within the young women, the age, the very young, below 35. So for those who had a higher risk, so node positive, grade 3s and big tumors, chemotherapy was given. And in those who received chemotherapy and recovered menses afterwards, within a period of 8 months, the benefit of ovarian suppression was significant. For those who did not receive chemotherapy, because they had lower risk characteristics, tamoxifen alone gave excellent outcomes. So really 95, 98% disease-free and overall survival, clearly stating that not everybody needs ovarian function suppression. Now, what about the other comparison, which is tamoxifen ovarian suppression, aromatase inhibitor ovarian suppression? So for that, we have the SOFT trial, and we have also the TEXT trial, and they were analyzed together. And what I can tell you is that the benefit of an AI for premenopausal is very similar than the benefit for a postmenopausal. What do I mean? there is a more or less 4% absolute benefit in disease-free survival, but only a very small benefit in overall survival, meaning around 1 to 2%. So when you decide what to give, remember what we discussed initially. Compliance is an issue for young women, as it is an issue for any patient, but particularly for young women. Educate the patient why endocrine therapy is so important. Educate the patient about the side effects. Try to discuss which side effect is bothering more the patient, and how can you help the patient to overcome the side effects, because if you do that, there will be a higher probability that the patient takes the medication. And remember that an aromatase inhibitor with ovarian suppression is highly toxic, namely in terms of sexuality, vaginal dryness, hot flashes, and so you should suggest that treatment only when the risk is really very high, so that the trade-off compensates for the higher side effects and lower quality of life. So these are all the factors that you should take into account when you propose the different options and decide together with the patient which one is better.